Hi everyone, the chapter that I selected is Chapter 10, Rheumatologic Disorders. There are four main disorders that I'll be going over: osteoarthritis, rheumatoid arthritis, systemic lupus erythematosus, and gout. For osteoarthritis, some general characteristics are: it is a non-inflammatory disease. It has degenerative changes in the joint. It is the most common form of arthritis in the United States. It affects 40 million people per year. Between 70 and 90% of Americans older than 75 years of age have at least one involved joint. It affects men and women equally, and symptoms seem to occur earlier and appear to be more severe in women, and the etiology of this disease is unknown. Some risk factors are age greater than 50 years, obesity, especially in the weight-bearing joints, exposure to prolonged occupational or sports stress, a high bone mineral density, crystals in the joint, prior injury or trauma to the joint, peripheral neuropathy, and joint hypermobility or instability. The main symptom of osteoarthritis is pain on one or only a few joints. Joints such as the hands, the hips, the feet, the knees, the cervical, and the lumbar spine. Morning stiffness is seen but usually lasts for no longer than 30 minutes. On physical examination, crepitus and a limited range of motion in the affected joints may be present. Deformities and subluxations may be seen, as well as bony overgrowths. A diagnosis of osteoarthritis can be made by history and physical examination. Now, the metacarpophalangeal joint of the hands, also known as the knuckles, are usually spared. This distinguishes it from rheumatoid arthritis. The goals of treatment for osteoarthritis are to improve function and quality of life. This involves both non-pharmacologic and pharmacologic management. For non-pharmacologic management, this includes patient education, physical and/or occupational therapy, and exercise. For pharmacologic management, this should be tailored to the patient to avoid potential adverse effects. Acetaminophen is considered the first line of treatment. Aspirin and non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen is another option. Now, in certain populations such as older adults and those with comorbid medical conditions, non-steroidal anti-inflammatory drugs should be taken with caution because these may cause serious upper gastrointestinal bleeding and potential kidney toxicity. Now, if both therapies fail or treatments fail, the patient may be a candidate for surgery, and then a referral to an orthopedic surgeon may be necessary. Now, because there is no cure for osteoarthritis, patients will need to adjust to living with the condition. Activities of daily living may need to be modified, which may include both physical and occupational therapy. Now, moving on to rheumatoid arthritis. Rheumatoid arthritis is a systemic autoimmune inflammatory disease. It is characterized by symmetrical synovitis, joint erosions, and extra-articular manifestations. It affects 1% of the adult population. Women are more affected than men, with the peak onset usually occurring between 30 and 50 years of age. Most patients with rheumatoid arthritis experience a chronic fluctuating course of the disease that, despite therapy, may result in progressive joint destruction, deformity, disability, and even premature death. Some of the factors of rheumatoid arthritis is being a female, having a positive family history, older age, smoking, and previous silicone exposure. And for this disease also, the etiology of rheumatoid arthritis is unknown. Pain and swelling of the joints are the most commonly seen symptoms in patients with rheumatoid arthritis. The proximal interphalangeal joints or middle joints on fingers and the metacarpophalangeal joints, also known as the knuckles of the hands, are commonly involved, with the distal interphalangeal joints being spared. Other joints affected are the wrists, elbows, shoulders, cervical spine, knees, hips, ankles, and joints of the feet. Symptoms such as fever, fatigue, and weight loss. Morning stiffness can last longer than an hour. On physical examination, affected joints will be boggy, tender to palpitation, and warm. Here is the criteria for rheumatoid arthritis. The picture on the right shows you the interphalangeal joints, which are the middle joints on the finger, and the metacarpophalangeal joints, which are the knuckles that are mostly affected with RA. Managing rheumatoid arthritis. The treatment goals of rheumatoid arthritis are to control joint damage, prevent loss of function, and decrease pain. There are pharmacologic management and pharmacologic treatment for the disease. On the right, you see a table with medications used in rheumatoid arthritis. You see ibuprofen, prednisone. You also have the disease-modifying anti-rheumatic drugs. The very first one is a popular one that everyone is familiar with, hydroxychloroquine. These drugs should be started 3 months of diagnosis to prevent joint damage. If untreated, about 20 to 30% of patients with RA become permanently work disabled within 3 years of diagnosis. Because of this, care should be initiated early, involving a primary care provider, rheumatologist, occupational or physical therapy, social worker, and an orthopedic surgeon. The next disorder is systemic lupus erythematosus, or SLE. SLE is a chronic inflammatory autoimmune disease. It affects mainly women, usually in their childbearing years. The prevalence of SLE is 1 to 1,000. The course of disease is marked by exacerbations and remission and can be life-threatening due to end organ damage, particularly in the kidney or central nervous system. Again, the exact etiology of SLE is unknown. Some risk factors of SLE include genetic, immunologic, hormonal, and environmental factors may be involved in its pathogenesis. It is most common in African Americans and Hispanics than Caucasians, and a strong family history is a great factor for developing the disease. SLE manifests as a mixture of symptoms, such as fever and fatigue, with skin, musculoskeletal, and mild hematologic involvement. Skin involvement includes a milder skin rash, such as the picture on the left, or discoid rash upon physical examination, like the picture on the right. This chart lists the criteria to help understand the signs, symptoms, and diagnosis of SLE. Malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, renal failure, the list continues. If at any time the patient has 4 out of 11 from the criteria list, the diagnosis of SLE can be made. Managing SLE. Since SLE is a chronic disease without a cure, the treatment is to help manage symptoms and prevent flare-ups. Medications such as non-steroidal anti-inflammatory drugs and corticosteroids are used to help relieve joint pain and swelling. High-dose prednisone may be needed to treat severe complications. Referrals to ophthalmologists, dermatologists, nephrologists, cardiologists, neurologists, or orthopedic surgeon may be warranted if the disease becomes severe or complications develop. Lifestyle changes must be implemented, such as patient education, counseling, and support groups. Patient education and support groups are for both the patient and the family. Patients should be strongly advised to wear sunscreen when out in the sun. Exercise and diet are also necessary to maintain a healthy lifestyle and prevent the side effects of any medication. Routine health maintenance and immunizations are also strongly advised. The last disorder we're going to talk about is gout. Gout is pain characterized by deposition of monosodium urate crystals in the joint or soft tissues, the most common form of inflammatory joint disease in men older than 40 years of age. It usually presents about 20 years after puberty in men and about 20 years after menopause in women. It is caused by altered purine metabolism leading to the buildup of uric acid. Gout progresses through the following 4 phases: asymptomatic hyperuricemia, acute gouty arthritis, intercritical gout, and chronic tophaceous gout. Gout is described as a sudden onset of acute joint pain with erythema and swelling. This often occurs at night. Some patients state that they cannot stand the weight of a bedsheet or wearing socks. The pain is set limited and will last 5 to 7 days. Joints affected can be the midfoot, the ankle, the knee, the wrist, fingers, and elbows. Symptoms include fever and malaise. Diagnosis can be made only with the aspiration of joint synovial fluid and visualization of monosodium urate crystals under a polarizing microscope. Here are some pictures of gout in the hands, the foot, and the elbows. Gout management. The goal of gout treatment are symptom control for acute attacks, risk factor modification, and prevention. Medications used in gout. Some include non-steroidal anti-inflammatory drugs. These should be used for acute gouty attacks. Indomethacin is the drug of choice, however. For prevention of flare-ups, colchicine, among other ones for hyperuricemia. Reducing the amount of red meat, seafood, alcohol consumption, and implementing diet with exercise will help to manage the disease. I chose this chapter because RN runs in my family, and even though I haven't been diagnosed with RA, it's a disorder that I have to keep in mind. So thank you for your time, and have a good day.